This is Healthcare That Clicks, where healthcare, innovation, and big ideas collide. No fluff, just the strategies reshaping the future of care. Here are your hosts, Ryan Kelly and Will Moon.
Hey guys, welcome back to Healthcare That Clicks. So today we are talking about the Trump administration's Rural Health Transformation Fund. Mississippi just received over $200 million in rural health funding. And here's the real question. Will that money build access or will it just build infrastructure? So over the last decade, we've invested heavily in telehealth and broadband through other grant programs, but the rural ERs are still crowded and chronic disease rates in our state are still super high and hospitals are struggling. So today, Ryan and I want to talk about some of the programs that actually work, where we focus on remote patient monitoring or chronic care or EMR integrations, wearables, AI, all of those wonderful digital tools. And more importantly, focus on how we can make sure that funding doesn't just install equipment, but actually changes patient outcomes. Hey, Ryan, how are you?
Doing great, Will. It's an exciting, hot topic right now. I know a lot of people are viewing this podcast today wanting to know some answers of some of the things that we're going to talk about and still have some of the questions that we're going to have questions on before we get done. One thing I wanted to be sure and note, rarely do we put the date of a broadcast of our podcast in, but I think because the information is so timely now and will become so dated soon, it's important to note this was broadcasted on February the 6th, 2026. There's a lot of information that's going to come out within the next 30 days, especially the next 60 days. And so just note that the information we talk about today, some of the questions we have may be answered. And some of the details as far as the application that comes out, you may be able to search for and find. So just note that. But many of the ideas that we explore today will still be very valid, and we think this will have a decent shelf life. But just understand that some of the questions we have will be addressed and answered in the subsequent weeks ahead.
Yeah, I think today it's more of a discussion around the opportunity and less of the mechanics, because we don't know a lot of the funding mechanics just yet. We do know, based on timelines, I think we saw that this month we're supposed to start seeing some RFPs, and I think there's a 3-week response period. So hopefully those are on time and we can all start having a look at what that process is going to be like.
One thing about this Rural Health Transformation Fund, and for those who don't know what this is, as Will said in the intro, this is part of the One Big Beautiful Bill signed on July 4th, 2025, 4th of July bill. And one of the many elements of it was to create this fund. Every state applied to the federal government for the money. There was an algorithm that was basically used alongside the applications from each state that divvied up money to each individual state. Note that because we are in Mississippi, we're going to be focusing on the Mississippi application and the details from Mississippians. However, this is applicable for any state. Just note that the funding amounts may be different, the mechanisms may be different, but again, the details that we're talking about are pivotal to all, because with the Rural Health Transformation Fund, one of the biggest components is the integration of technology into innovation and transformation in rural healthcare. That's across the board with RFK Jr. and Dr. Oz in DC now. That is a huge point that they wanted to make, is integrating technology into medicine. And so because we are so integrated into telehealth into Mississippi, Will and I am, we wanted to be sure and cover that in this podcast, because that is going to be a major element of everyone's application, at least indirectly, if not directly. And that's a lot of what we'll talk about today.
Absolutely. Absolutely. All right, Ryan.
So, you want to get into some of the tenets, Will, of Mississippi's application? At least we kind of have 6 major buckets, as I like to call them, of guideline that we think these RFPs are going to come out under. So do you want to get into that for us real quick?
Yes. So I just had them pulled up and now. All right. So
I can cover them if you'd like.
Yeah, we've got 6 pillars. And since I lost it, Ryan, what are the 6 pillars?
Sure. So the 6 major pillars, and again, this is specific to Mississippi, but many states are going to have some of the same ones. The first one is a statewide rural health assessment. We do an assessment of sorts in the state every year. This one will be much more robust, kind of planning out rural healthcare for the next decade. And I've had the pleasure of being able to lead some of these for Mississippi. And so I think this is very important. And hopefully we'll have a lot of legs to guide us as we have this huge amount of money that we get to allocate towards these different needs. Number two, coordinated regional integrated systems initiative. This is going to be something much more of like a systems delivery of care, possibly clinically integrated networks or ACOs. This is going to be a major component of what we do with this money to help truly transform rural healthcare in the state. Number three, workforce expansion initiative. This is one we'll talk about a bit today because we're not exactly sure what this could look like. I would expect a good bit of this money going to some of our community colleges and four-year universities, in addition to some other training programs. A lot of hospitals and other institutions have localized training programs that might be available for this. And there's some other things that could go into it as well, possibly recruiting benefits and those sorts of things. Number four, health technology advancement and modernization initiative. This one could very much be a backbone of health-related technology, as we'll talk about today. Could involve electronic health records, although there's some limitations of what the fund can do with that. Could involve broadband expansion or further broadband expansion and the like. Number five, this one, of course, is near and dear to me and Will, telehealth adoption and provider support initiative. This is directly focused on expanding access to telehealth and telemedicine services, which, of course, is great and something that Mississippi's been a leader in for a long time, and hopefully it will continue to push us forward. And then number six, infrastructure and care capacity strengthening. This is one of those things specific to rural health we know we have a major issue with, both access to care and being able to have a carrying capacity within our rural hospitals that helps to hedge off the influx and the flow into our urban hospitals. If you think back during the COVID time, how urban hospitals got overwhelmed because the rural hospitals got overwhelmed, and the amount of capacity for care was diminished in rural, and it got overflowed into our urbans. And so we need to make sure that the capacity in rural is substantial enough to not only help with the day-to-day needs, but also if there is some sort of a, dare I say, a pandemic level event, we can carry the capacity in rural so we don't just completely overflow in the urban. So, Will, those are the six primary pillars that Mississippi has. And again, a lot of these are going to be universal across the board. I would expect workforce to be in almost every state, something related to telehealth and telemedicine, something related to infrastructure, something related to the integrated systems of care. They may be called something different, but I would expect those to be in most every state. Other elements like doing a statewide rural health assessment may be specific to some states or another. And then how much technology is integrated into all of the elements versus how much is it integrated into just one element may be specific to each state.
Yeah, and I think a good way, Ryan, to summarize the six pillars for Mississippi is and it's not a new topic of conversation. It's one we've talked about for a long time, but how do we keep care local? And a lot of that is related to access. So how do you provide more access to keep care local? Because when you're meeting patients where they are and taking care of them where they are, we've just seen this, you have better success rates. When patients have adequate access to primary care and specialty and other modes of care, whether it's through telehealth or digital tools, you just see an improvement overall in the population's health versus where they have to travel for care. Because, one thing that we see, especially with the modern healthcare system, and I'm very guilty of it, but convenience. Like if it's not convenient, maybe I just skip that doctor's appointment, or I don't really want to drive 30 minutes to go there, to get that x-ray or whatever it is done that I need to. So I think meeting patients where they are, providing that access is a lot of what we're talking about here. Assessing the needs for the state, making sure there's integrated systems. I mean, the second and sixth pillar, the integrated systems and the infrastructure for delivery and growth, a lot of that is, how do we equip hospitals so that they can keep care local and have fewer transfers out, because that's one of the things now that's killing the local community hospitals.
That's right.
They're getting patients in that are just a little above the acuity level they can handle, so they transfer them out and lose that patient revenue.
That's right. Absolutely. So one thing I want to talk about today is to help answer one of the questions I know everyone has, at least at this moment. So, money has been awarded to the state. Where do we go from here? And I'll be honest, I don't fully know the answer to it, but I'll give you as much as I do know, and then also the timeline of what I would expect. And then from there, we can get into maybe some of the examples of some of the RFPs we would expect, and then maybe some ideas of what people could do. So, if everyone's familiar with Horn, a CPA firm, based here in Mississippi. They recently merged with a national company called BDO. A BDO does a lot of different things throughout the country. One of them is to help lead efforts like this for states. And so I know several of the people there with BDO and have spoken with them, worked with them on the process of this rolling out to Mississippi and other states as well. They are doing work behind the scenes right now to prepare internally for the mass volume of what is inevitable once these RFPs come out. And we do expect those to be pretty soon. As Will said in the timeline for Mississippi's application, sometime before the end of February, it's stated that the RFPs will come out. That is possibly true. I could see it bleeding into March, perhaps, but as according to the timeline, they should come out before the end of February. These RFPs possibly will go through OpenGov in Mississippi. That's our government transparency site that everyone can bid on contracts and subgrants through the state. It is possible there may be a separate site that Mississippi would use for those subgrants. And again, if you're from other states, every state will be a little bit different on where those come from. But I would go ahead and expect there to be a good bit of information about your organization, the basic things, obviously, your contact person, your address, EIN, the financials of the organization perhaps might be asked. I'm unsure if it would be required to have a SAM.gov ID number or a DUNS number. If you don't know what those are, I'll just invite you to Google them. You might want to consider getting a SAM.gov ID number if you don't have one. I'm unsure if that would be part of the process, but to be on the safe side and to not slow you down, because this is a fast moving process. If you're used to the way government normally works, this is not the normal government work. The money was awarded to all of the states at the end of the year. We're already in the very 1st of February expecting RFPs to come out. There will be about a 3-week period before those RFPs close, and then the money will be awarded shortly thereafter. That is not a normal government process. This is hyperspeed for government, which also means there could be some things falling through the cracks. Right, Will? We've seen that happen before.
That's right. Yeah, it's like, right, so you get $202 million in funding for this year. Oh, but we're not going to give it to you till like April or May. So, figure out what to do for the other 6 or 7 months of the year.
Yeah, and we saw the best example I have of this is if you think back during COVID, we had a lot of money that went out in the EIDL loans and the SBA loans and the Paycheck Protection Program and all that. And there was, at that time, I think we learned, so I'm not suggesting that's what's going to happen now. I think we learned there was fraud, waste, and abuse that took place when things go fast. And when we don't have the checks and balances needed, there's always things that can fall through the cracks. I believe the Trump administration is going to be very strict on the use of these funds to make sure that every I is dotted, every T is crossed. That's where I think a lot of the work has taken place between the award from the government to the states and now the states to individual contractors and organizations. They're making sure everything is lined up so we don't experience some of the issues that we've experienced in the past, to make sure every dollar is used wisely, every dollar is used for the intent of what the money is for.
Right.
And the reporting requirements, from what I understand, are very strict from the states back to the feds. And so the states are going to be very acutely aware of where money goes and how it's spent. And I expect very little, if any, fraud, waste, and abuse to take place during this program, only because of how acutely aware everyone is of what's happened in the past.
Yeah, there's still some PTSD, I think, from the COVID era. I think people will, to your point, be extra careful, pretend like they're walking on eggshells a little bit. Also, I mean, not to just skip over it, but I mean, we are Mississippi guys, and just for a second, I think we should recognize Horn and their accomplishment. I mean, you've got a company started in Ridgeland, Mississippi in like the 60s that grew to be one of the top accounting advisory firms and exits for $300+ million. I mean, monumental. So shout out to Horn. Good job, guys.
Absolutely.
I think the rural health assessment and some of the like the choice with Horn or BDO, a lot of those things are positive steps that the step has made to also help show the feds like, hey guys, like, we're trying to make sure our quality controls are in place around, the grant applications, the funding, the distribution of funds, and everything else.
That's right. And I feel good about it. Like I said, I know some of those guys. I know, Will, you know them as well, guys and gals who work for Horn and or BDO now. They're going to do a very good job. They're going to represent us well. And one thing I'll say too, and again, specific to Mississippi in this, we have looked great in the process. Many other states have, from the transparency side that's taken place so far. I know some people would love even more transparency, and I understand that.
Sure.
But the process of gathering information from our constituents and being able to go and present those to the governor and his team, and then for those to be integrated into the plan that we have that is posted on the governor's website now. Will and I just reviewed that again this morning before for this podcast. We had a lot of transparency in this process. Now, I know now, in this little window of time, we're all just kind of waiting with bated breath to see what happens from
What
here.
happens next?
By the time you're listening to this podcast, we may already know. But this sometimes there's a quiet before the storm. That's where I kind of feel like we are right now. The floodgates are going to open. I can tell you just from the association side, from the Telehealth Association and some of the others that I'm a part of, I have probably talked to or received information from every vendor in the technology space in this entire country. If I ignored your email, I apologize. I literally get 20 a day and probably just as many phone calls. So they're just about impossible to field, which is going to go and say one thing. This application process is going to be intense. There are going to be a lot of people applying for these funds. I will go ahead and just say this right now. A lot of people have the same ideas. So if you are not awarded, don't think that your idea was not liked or appreciated. It just means it may not be unique to what was observed and found in these in this RFP process. But with that said, Will, I definitely want us to get into some ideas.
Yeah, I think that's a good segue.
Yeah. So what are you thinking? I mean, you've seen the RFP that the state applied to. You've seen our plan now with the different buckets, as I like to call them, tranches of money. What are some ideas you've had? You're a creative guy. You come up with a lot of just fantastic ideas. What do you think are some of the ideas that are going to be coming up with from the result of the RFP process?
I think it's a good question. And I think the first question that we have to ask ourselves is, all right, if we're going to be serious about access, outcomes, and sustainability for the funding that we're trying to use to make a difference, right? What are the smartest technology bets that we can make to do that? And obviously, I'm going to be a proponent of what we're doing, which is going to be a mix of chronic disease management or remote patient monitoring the behavioral side of things. So the ways that patients act and think about, not just depression and anxiety, but, medication adherence and overall acknowledgement of taking better care of yourself and some of those things. And so, when we think about that, if we're going to take those things seriously, the access and outcomes, and do it in a way that actually lasts, what are the technologies that are going to be there? And that's where I think a focus on chronic patients is super easy, just because we already have plenty of models and tools out there, whether it's using remote patient monitoring and issuing the patient a digital blood pressure cuff or monitor that links back to a nurse who monitors and looks at vitals and consistency and, tries to identify trends or readings that are outside of normal ranges, some of those things to be proactive, to prevent the acute visit to the ER or the hospital. Those are some tried and true tested ways over the last decade that we have that just seem like, have been slow from an adoptive or an adoption standpoint. And I don't know exactly what that is. I kind of have, some theories. I think the market is getting a lot better and more attractive for the practices and the providers that are out there to offer some of those tools. Obviously upfront cost for purchasing devices is a big stopgap there, but, just using that as an example of a way to focus on chronic conditions for perspective when we think about improving health. If you look at Medicare alone, Medicare as a nation as a whole spends around $1 trillion a year on care for their beneficiaries. Within that, you've probably got $700 to $750 billion that are spent treating patients with chronic conditions or patients that have an acute event as a result of chronic conditions. So tackling chronic conditions is a big aspect. And I think, we saw this in the Rural Health Transformation Fund. In the fund on their application, I think it was 50% of our state is hypertensive, 40% is obese, 35%, or I'm sorry, 20% had diabetes, 35% had arthritis. We've got tons of chronic diseases through our state. And we see this with the work that we do at Link. And these patients, benefit like greatly from the program.
Yeah.
75 to 80% of my patients in a remote patient monitoring program are going to see blood pressure control. And these are just tangible ways that you can reduce ER visits. And Medicare themselves are like, hey, for every patient enrolled in one of our chronic programs, we save around $3,000 to $4,000 a year because you're preventing ER visits or unnecessary urgent care or whatever else it may be. And so those are just some tangible ways with tools that are out there now that need, a push within the state from an adoption standpoint. I mean, I think there's over 600,000 Medicare patients in our state alone, and maybe 10,000 are on RPM programs, maybe. So just as an example there, when we talk about real live or real world digital health solutions that can actually make an impact, anything on the chronic space, it could be remote nursing, it could be the monitoring devices, it could be wearables, to know when patients are off balance or falling. I mean, some of that tech is getting incredible. Like there's an app now where you can take a video of a patient walking and it will like measure their gait and do a fall assessment risk.
Mm-hmm. I love those. It's amazing. And I think you're exactly right, Will. I mean, and some of this is preaching to the choir. Obviously, we're very involved in telehealth from the Telehealth Association and from what you do with Link Healthcare. And, this is going to come natural to us to say that chronic care management and remote patient monitoring are the best tools that we have right now to help treat chronic illness and all of the big things that affect a lot of our states, like Mississippi and a lot of our southern states. And the solutions to those are actually pretty simple. That's the funny thing is there's a lot of prevention we can do. There's a lot of education that's involved in this. They just need help coaching. The tools that we have are already there. We just need better adoption. And that's where I'm hoping that the integration of that rural health assessment side, the money and tremendous amounts of money that we're talking about, guys. And we're 200. What was our allocation for Mississippi alone? 200 and how many million for the first year?
It's a little over two. I think it's like 202.
202. And that's just the first round.
Yeah.
But there will be
That's
more.
year one.
I
It's a
predict
5-year program.
Say that again?
I said, that's just year one. It's a 5-year program.
Exactly. I'm predicting Mississippi to get somewhere around, I could be wrong, somewhere around $700 to $800 million over 5 years. That's my personal prediction of the state. Just given the language from the bill, the rurality of the state, the fact that we have such great need, we're doing a good job with the application process, the transparency. I think our reporting is going to be good. I would expect around 800 million coming into Mississippi over 5 years. We've never had that before. That is a tremendous amount of money, specifically for rural healthcare and specifically for the integration of technology in rural healthcare. Literally, in my opinion, this is one of the greatest opportunities for the advancement of telehealth in our history. And I expect that over the next 5 years, if we use this money correctly and wisely, I think we're going to see a push into telehealth like we've never seen before. That includes COVID.
Yeah. And just for, the listeners and for us as a reminder, pre-COVID telehealth adoption nationally and even in the state was maybe 2-3%, of claims you would see that were telehealth claims. Most of those were behavioral or mental health. And I think a large portion still are behavioral and mental health. And you had a surge, obviously, through COVID. I think even in Mississippi, it got up to 30 or 35% telehealth adoption rates. But now, I mean, post-COVID, it's not only has it dropped off nationally, it's almost kind of embarrassing to see like where it got with COVID. And so everyone saw the potential and they got to use the tools and see a benefit. And now here we are. And I mean, we're probably between 5 and 8%, so we've gone from 2 to 3% pre-COVID to 5 to 8% post-COVID, in terms of, total claims and the percentage of telehealth that's done within that. I mean, it's really low adoption.
And I think the crux of that is probably important to what we want to talk about today. or continue to talk about, which is the why.
Mm.
Why did we go up so much? And I think we know the answer to that. But then why did we go down so much? I think for me, the answer to it is normalcy. We haven't created the new normal. That was the what was that, 2020 to 2022? Everyone says the new normal, right? I mean,
Hmm.
how many
Hmm.
times did you hear that? Well, the new normal never really happened. We
No.
went back to the old normal. And in some ways, gosh, I'm thankful. We're not wearing masks indoors anymore, and the 6 feet apart thing. I mean, good gracious, I'm so tired of that. But telehealth, we thought would be a new normal.
Right.
And in some
Right.
small cases, like you said, it has, we're double or triple where we were pre-pandemic, but nowhere close to where we thought it might be because everyone resorted back to the in-person care. It was
Mm.
the normal thing that facilities did. Clinics, they went away from the drive-through for the most part. Some kept it, but most got away from the drive-through clinics. They treated you in the parking lot. I thought that one might last. People
Yeah.
really liked it, both providers and patients, but it wasn't normal. It was different. Telehealth is good. They like it. It's actually efficient for the providers, efficient for the patients for the most part, but it wasn't normal. And
Mm.
so I think that's one big element we're going to have to do if we're going to talk about rural health transformation. Transform means we're going to change. And so we're
Right.
going to have to change what the normal is for everyone. And only then are we going to truly get to actual adoption. What do you think, Will? Am I off base on that?
No, I think you're spot on. As you were talking, it kind of made me wonder. I hadn't thought about it before, but it was almost like the pandemic set us up for a big surge in telehealth
Mhm.
adoption. But it was an interesting, like, I wonder if we peel it apart, I wonder if the adoption came more from or at the practice level rather than the consumer level. Because I think what we saw with the pandemic was, and you and I know this from being in telehealth for a decade or more now, but I just even to get a clinic to adopt telehealth as a tool, to have an option for patients to do telehealth visits or remote visits or something was still a hard kind of uphill battle pre-COVID. And post-COVID, oh yeah, sure. Like, I'll implement this tool and maybe we'll use it, maybe we won't, but it'll be an
Mhm.
option to my patients. That's
Mhm.
become a little more normal, right? But the usage hasn't gone up because the patient or the consumer adoption. And now it's adopted more on the clinical side and given as an option to the consumer, but the consumer hasn't chosen it as
Mhm.
often. And it's almost because the duality of when the practices adopted it also set up the perfect storm for consumers to not want to adopt it because they didn't choose it. They were forced into it. And then they were forced into mask and staying at home and 6 feet,
Mhm.
social distancing
Right.
and all of that, kind of like created more of a yearning for in-person services, for social communities and connections. I mean, think about whenever we went back to normal, all
Mhm.
of the in-person events surged, attendance at
For
in-person
sure.
events surged. And so, people wanted to go back to the doctor. They wanted to go back to in-person care. They wanted to be, touched or seen or whatever instead of just remote. It was almost like this perfect storm, that allowed for greater clinical adoption, but, almost like, prohibited some of the consumer adoption because it
Mm.
wasn't organic, it was forced. And
Yeah.
anyway, that's
Yeah.
that's kind of my take on it.
No, I think it's a really good take. I like it because, yeah, like anything, if you're forced to do it, when you stop being forced, you're not going to keep doing it again,
Huh.
unless you're talking literally generations of people that grew up with something. But that's not what we're
Yeah.
talking about. We're talking a very acute level of time for most everyone, with the possible exception of maybe your and my kids who were out of school for a little bit of time and they did work over their Chromebooks
Remote. Right.
MacBooks. So, some elements of that they got used to in formidable years. But for the most of us, yeah, it's a blip in the radar. Didn't seem
Hmm.
like a blip during that time, but it was a blip.
No, it seemed like it was never going to end, but
Yeah.
when I think of telehealth, I think a lot of the fear with telehealth originally was around the fact that it would replace in-person care or could
Mhm.
replace, something that was being done. And the reality is it's a tool, it's an enhancement. It doesn't replace, it allows you to do more or, you know, provide more convenient options to patients. Right.
For
And I
sure.
think within that, two things that we've seen a big success in just on the telehealth side is the remote patient monitoring and behavioral health. I mean, behavioral health to me is the clear winner with telehealth because it's helped destigmatize it. You're not going into a clinic with a mental wellness sign on the outside. If you're in a small town, everyone knows who the psychiatrist is. So it's opened doors for people that otherwise wouldn't have sought out that care before because of a stigma around it or not wanting to be perceived a certain way. So
Mhm.
I think that's a clear winner. And the behavioral side, especially when we're talking about patients with chronic conditions, is huge. So, like
Mhm.
when we think about the Rural Health Transformation Fund access, I think behavioral access as being a big component of that, just
Mhm.
because a healthy patient is going to care more about, showing up for their appointments, filling their prescriptions, eating correctly, doing some of the preventive things that we want them to do
That's
to
right.
keep them healthy and out of the hospital.
That's right. And that really boils down to so much of what we need to be doing. And this is something that technology can assist us with from the health education standpoint, but we don't have to use technology. It's just a good tool for us to use. People need to own their own health. We've said
Mm,
that many times before. Understanding how God made our bodies, how our bodies work, that we
mm,
put into our body, and that becomes the actual literal building blocks of who we are. So if you eat an apple versus you eat fried chicken, well, the apple is going to be a lot better for you than the fried
right.
chicken. I love fried chicken, don't get me wrong, but I eat it once a
It's great.
week, not twice a day. Size, and we need to continue to keep our bodies moving.
Mm,
Eat foods that are not going to cause inflammation. You mentioned the 35% arthritis. That is crazy high number. If we eat lower carbs, higher protein. We don't overwork our bodies. Keep it, we stretch, we move. The rates of arthritis would plummet, just like diabetes and hypertension and
yeah.
obesity, all the other obesity related illnesses. That's education,
Mm,
people understanding and then being willing to do the things that they know. So education only
great.
comes as far as motivation. But that's where, again, chronic care management, remote patient monitoring, the telecoaching that we have, the
Yes.
apps that you can wear that remind you plug in your calorie count. It monitors your steps and your movement, and it gives you a basic calorimeter for the day. All these tools we've got. We just need adoption, utilization, and then if we really wanted to take a transformative approach, the integration of that into the electronic medical record for your provider to be able to help monitor and coach you, even if you're not of chronic illness. I don't have a chronic illness. I don't have a comorbidity, but I'd love to track that data, track my sleep, and be able to monitor progress over a period of years and see if my blood pressure is spiking at all. Is it not spiking, but is it elevating some? Am I having more pain over a long period of time? And is that
Right.
indicative of a nutrition issue or a workout issue I'm having in the gym? Those are the things I'd love for us to get into because, and then of course, the reimbursement for that from providers is there and it needs to just continue to be enhanced. But that is true healthcare. And that's not sick care, that is healthcare. And
Yeah.
that's what we're talking about.
I think it's the way you kicked off that was so interesting. I had a doctor tell me, an ER doc, tell me many years ago that if every patient or if everybody in general exercised properly, ate well, got 8 hours of sleep every night, and tried to maintain low stress in their life,
Mhm.
most doctors in the country would be without a job. He was like most chronic illness would start to go away because it's tied to lifestyle, healthy living, and a lot of these things. It's kind of like, I think, some people have kind of referred to it like a car before, like you've got to service it, you've got to care for
Mhm.
it, if you want it to last. And it's kind of how we have to take care of our bodies in a similar way. So I agree, there is that individual responsibility that goes along with it. And a lot of that comes through education, like you're saying.
Mhm.
And that's a big thing that's hard right now. Like when we look at these pillars for the Rural Health Transformation Program, one of them is workforce, right?
Mhm.
Workforce is on there because like you and I have talked about before, there's not enough nurses. There's not enough, support staff that do a lot of the groundwork or the, day-to-day work in these practices, in the clinics, in the lives of these patients. And not having that, an adequate amount of that, you end up getting, a bunch of clinics or practices out there that are understaffed and overworked, and everyone's just trying to get to the next thing. But
That's right.
adequate staffing creates space for education and for patients to be aware of certain things. Because a lot of our patients that we work with, they just don't know. It's kind
Mhm.
of one of those things like you just don't know what you don't know.
Right.
And whenever you have someone who can look at that holistically, and get an idea of what your goals are and what a doctor's goals are, or a care plan for you, and coach you through that process, it makes a big deal, or it can make a big improvement. And so all the different tools to be able to do that are hopefully what we're going to see funded through this program. And one of the things I was thinking about also is the metrics. Like, how are we going to measure success of these programs? So we want to improve access, obviously. We want to keep our rural hospitals afloat. We want to make sure we have enough new entrants into the workforce, but when we look at it overall, we're talking about the patient, because the patient's at the center of all of it. So what for the patient are we going to measure as the improvements, right?
Yeah.
Are we looking at avoidable ER visits, admissions, time to appointments, chronic disease control, blood pressures, A1Cs, patient engagement? How often are patients adherent to office visits, annual wellness visits, or their annual checkups, or filling prescriptions with the pharmacy? Even, like we are just talking about workforce, like clinician capacity, trying to figure out better payment models or better ways for doctors to get paid so that they're not, right now a doctor's got to get through, 35 to 50 patients a day to make the numbers work for his clinic.
Yeah.
Well, that puts you at like 6 to 8 minutes per patient on an interaction side, because you're going to have 20 to 30 minutes of paperwork on the back end or charting on the back
That's
end.
right. That's right.
And so how do we do these things where, like, even clinician capacity, because what we see with the practices that we work with some practices that, are in the rat race, and they have to see a certain number of patients based on volume. We work with some other practices that have chosen a different path, and they have smaller patient panels, and they see their patients more frequently, and they, try to, stick to 30 to 60-minute visits per patient. So,
Yeah.
enabling some of those types of care would also be a big thing.
Yeah. No, I think you're exactly right. So I want to get into some ideas of where some of this money can be used. And I think some of that is going to integrate into what you just said here. And some of it we've already talked about. So the
Right.
obvious, the telehealth, the telemedicine, the remote patient monitoring, the hospital at home program, I think
Yeah.
is a really interesting one. One quick aside, as of this podcast, several of the budget bills did pass. And so that did kick out our Medicare telemedicine reimbursement into 2027, which is very, very good. And also of recent, the hospital at home program was kicked out until 2030. So that means that both of those are now fully reimbursable, and we can finally stop having to worry about it for a little while. Hopefully, the Connect for Health Act, which is not passed right now as of this recording, gets passed, and that would make those permanent in code. So that's very much what I know we're all hoping for. But so hospital at home, I think, is a great program that helps to hedge
Oh,
off
yeah.
some of the capacity needs of facilities, because the patients can stay at home if they're able. Utilizes telehealth. I think that's a really great program. We talked about interoperability a little bit, and when we talked about EMRs or electronic health records, we're not there. And I'm not sure, maybe I'm just a little negative on the state-based health exchanges, but until we get a patient identifier, we're not going to be able to do a true interoperable health exchange aside from one specific EMR type. Like if everyone had Epic, then that's basically interoperable. You can go in, you can modify charts, you can see information. But when you have a state-based health exchange, I'm not saying we shouldn't do it, but it's kind of like it's a one-way street. All the information goes into it, but then you have to log into the exchange, and then you have to make sure that the patient from one facility is the same patient from another facility. I'm not as bullish on the HIE, although that is a big thing that's been talked about with this money. Maybe we'll have another state-based exchange. We've had one at one point, and we got rid of it, and maybe there'll be another one. But in my opinion, if we do that, we've got to have a patient identifier to where John Smith from one facility is John Smith from another facility. Workforce, we talked about that. We can talk about workforce a little bit more. Big questions around workforce. Huge component of this. We know we need workforce capacity. It's a huge issue, particularly in nursing right now, but in many other instances, I could think paramedics, EMTs. There's a lot of areas of workforce that we need to focus on. Access points in the community. This is something kind of clever that we could think about. We've talked about schools. We've talked about hospitals in the past being logical areas of telehealth and teleconnectivity. I could even see private businesses. We've got some
Yeah.
examples in Mississippi of that where they're they in their self-insured plans, they have telehealth and telemedicine programs built in, apps or kiosks or whatever, where you can go and do that. I think the OnMed system, the big robust platform that you can get into, and you have a provider come on, it can do the biometrics. That would be an element of an access point, I think, as well. And then one that's kind of overlooked a bit is cybersecurity.
Yeah.
That is huge right now. Fortunately, I haven't heard of as many cyber attacks lately, ransomware and the like. But also, my emails don't go through to half of the facilities anymore because their firewalls are so intense, we can't get
Yep.
anything through. And so they're basically crippled because their shields are up and you can't talk to them anymore. So cybersecurity is a major problem still. As everyone I'm sure has heard many, many times now, your health record is one of the most valuable things in the dark web, and they would
Yep.
love nothing more than to take it. And so trying to make sure we have training and prevention and software needed to protect us from those is pretty pivotal. Those are just some ideas I had, though. Will, what do you think? What have I missed out of that little quick and dirty list there?
So one comment or I guess one counter that I would have for the HIE side, I'm not super bullish on anything statewide, but what I do think would be good if there was some carve out funding there for either individual practices or health systems, to make sure that they have a health information exchange that they tap into, so that they're getting a lot of these statewide reportings, and they can do some of the close some of the care gaps, do some of the research on what care patients have actually received. Like, I think it'd be great for primary cares to be able to tap into an HIE, because they get to see all sorts of things like hospitalizations, procedures, other specialty visits and whatnot. And, you know, especially when you're dealing with older patients, they forget when they went to
Hmm.
the doctor and what doctor they went to. And so anyway, just having access to some of those things to be more proactive with care on patients, kind of pitching it that way, like these exchanges do give clinics a tool that they can be proactive on patient care with instead of reactive. And that's another issue that, we could talk about another day, but the health system right now is set up so like you don't really know what you're going to get that day. Just someone shows up and you treat whatever shows up. And so
Yeah.
I think switching more to proactive models, even through, some funding like that. I know, what was it, 20 years ago, 25 years ago, whenever they did all the large federal funding and grants to adopt an
Hmm.
EHR or an
Hmm.
EMR,
Hmm.
there could be something similar like that, some sort of award there for incentivizing practices to, use these tools, get these tools, use these tools, and maybe help them pay for it. Everything else that you've kind of gone over, I think is, um, or has been addressed in the past, even all these pillars that we're talking about, they have been addressed in the past through other, grant programs or whatnot. And so that's where, and that's part of what we're doing right now is brainstorming, but that's where I'm trying to constantly think through, like, what do we do with like you said earlier, this is the biggest opportunity for rural health transformation that we've had, because we're about to get more money than we know what to do with.
Hmm.
This is a ton of money. This isn't just like, we're getting a couple million to lay some new, fiber optic cables, right? This
Right.
is
Right.
a big deal, and it's got a big mandate behind it, because the federal government's like, we're giving you a lot of money. We expect you to do something with it. And so
That's
I just
right.
keep thinking through, like, what are the things that are going to actually move the needle? Like there's been tons of grant programs and still are, through the USDA and other branches that offer funding for healthcare access within schools. So there's tons of options out there now for communication companies. And so that's where maybe that's what we need to think through is, what can we do differently?
Yeah.
Interoperability, as long as Epic's got 40% of the market, their whole strategy is to pretend like they'll work with you, make you pay them a bunch of money to spin up a management team, and then copy your model and ice you out. So, you know, it, as long as you have, large independent players like that, you're not going to have interoperability in the way that you want it. And so, that's another great question is, with a lot of the fragmentation that's there now, we do have some of the statewide reporting and networks, but how do we really get to interoperability? How do you I feel like companies have tried this before where, you
Mhm.
try to figure out an identifier for a patient, kind of like you were saying, so that they can be tracked,
Yeah.
across the sites of care.
Yeah, that's right. And we're gonna have to have that for interoperability. I mean, it's like your social security number. And maybe we use social if we could have the same number of digits for, a green card or whatever else. But until we get an actual identifier for all patients, I can't see a way to do that. If you're an Epic, they've got an Epic, I forget what they call it, the ID number within that system
Hmm.
that matches that patient everywhere. We have to have something like that in some capacity. But yeah, I mean, I'm optimistic about this. Maybe I'm just maybe an optimist by nature. I know some of the things we do are going to fail and they're not going to work, and that's fine. That's part of that's the scientific method, right? Yeah, do a hypothesis, you do an experiment, you test the results, and you come to a conclusion, and you modify after that. Some of the things we do are not going to
Yeah.
work, but what's the definition of insanity? Trying the same thing every time, and expecting different results.
Yeah.
We can't keep doing the same thing. We've got to try something different, and that's for every state. I mean, if you look at obesity rates alone from the 1970s until now, when we look at Colorado as the only state that's not just completely obese, but they are
Um,
significantly worse than they were back then too. We're all fatter, we're all sicker, we're all doing things worse. Healthcare facilities have never been in worse shape financially. We
mm,
know that we're in the wrong direction from healthcare. We have to change, we have to fix it. And my hope is that this money will give us the tangible tools to carry out some of the policies and the ideas we've had for a while and give us the true firepower we've always needed to push forward in a much more meaningful and beneficial direction. Because if we can't do it now, I don't really foresee us having an opportunity from a funding standpoint like this ever again. So we really need to get it right and get all of our ducks in the row, stop being territorial, and find really good common sense solutions that leverage technology, that leverage health literacy, health education, benefit hospitals, benefit clinics, benefit patients. Hopefully, I know you and I would agree with this, get government a little bit out of the way and let the industry and innovation thrive. Healthcare is one of the most strangled industries in our entire country when it comes
mhm.
to barriers to entry and guidelines we have to follow to do anything. I'd love for some of that to loosen out of this, and I think that with this administration, is probably likely to happen to an extent. I think if the stars can align and we can do all of these things, we could absolutely transform healthcare better than it's ever been in the history of our country. If we don't, it's just going to be a whole lot of wasted taxpayer money, and I know none of us want that to happen.
No, and I mean, you're hitting on something big right there, and that is, honestly, more of your area than, but one, like the money is one thing. Having the funds to do this, like, a lot of ammo to, accomplish this mission here,
Mhm.
right? But I think on the other side of the coin, to what you're saying is there's going to have to be a lot of policy changes or
Yeah.
regulatory changes that are going to have to go in tandem with this to get the most and best use out of $200 million a year,
Mhm.
and I don't know what those policy things would be. I guess one that I would think is if we could, even through Medicaid, honestly, if we could figure out how to pay different provider types or license
Mhm.
types
Mhm.
and incentivize them to be more a part of the care team, like a pharmacist, for example. When you're talking about chronic care, we're talking about medication adherence, medication reconciliations, a lot to do with meds, and the patient, and those are big things, but are pharmacists incentivized now to do those things?
Not really.
Not really. I mean, you could argue, yeah, there's a coaching or a review code out there or something, but I think it requires the pharmacist to like sit down and talk to the patient in person for like 30 minutes. What
Yeah.
pharmacist is going to do
No
that?
one can ever do.
No, you
Yeah.
can't run a pharmacy and do that. You got
No.
to fill scripts. So,
That's right.
some of those things I think are also, worth exploring on the policy side, and
Mhm.
we're not going to have all the answers today, but just for anybody listening or for even us later, thinking through the ways that other people can get involved in some of the access. Like, we're not just talking about doctors and nurse practitioners, like trying to get patients more access to doctors and nurse practitioners. I mean, it could be diabetes educators. It could be health coaches in the form of LPNs. It could be registered dietitians. A lot of these other ancillary services that are super complementary. I mean, My average patient is a 78-year-old female. Okay. And diet, nutrition, meal planning comes up a lot in those conversations. So, and if we're talking about improving weight management or, cholesterol or blood pressure or anything else, diet's going to play a factor there. And
Yeah.
having a registered dietitian on the team and work with them for a care plan is a great way to have multiple, care team members that are, taking their own area of expertise to get the outcome that you want for this patient.
That's right. One of the areas that I think is so overlooked and such an opportunity, and I know I get myself into trouble every time I say it, but it's ambulances, emergency transportation. And this falls very much in the line of technology. So one of the very first uses of AI that I saw in the healthcare space was with a very large ambulance company. And I went into their little control center and they had all the computers set up. It was like, you're what you imagine like a dark war room to look like. It's like all
Yeah.
black around. You got all the monitors and they've got their trucks on here with a map. And it shows basically like a heat map of when there's the likelihood of an event happening based on your historical data, which of course evolves over the years as you get more data in. They're pushing their trucks around to where those hot spots are, which you can only do with capacity and you can only do with technology. So it's not one county with two trucks and they're just putting the truck at the gas station and the fire station and they're just hoping and waiting for the call. This company is literally moving their vehicles around in strategic areas based on the AI's predictability of out in the middle of the woods. There's a hot spot that comes up because historically at that time of year, there's people out duck hunting or deer hunting.
Yeah.
There's going to be some sort of an accident. So what did they do? They took a truck from a gas station and they moved it out to a country road to wait. And sure enough, a call came in of someone who needed one. It wasn't exactly in the bullseye, but it was close. That saved 15 minutes by just utilizing artificial intelligence to move that truck
That's
closer to
incredible.
where the likelihood of something happening was. And that is what we have to do to truly transform emergency transportation. You don't get that with a mom and pop ambulance company that covers one county. I wish it did. I love mom and pop businesses, but it can't work anymore. You've got to have the capacity. But see, that's a county issue in most of our states. That's not even a state issue. That's county by county, their management of their emergency transportation. We've got to rethink that from a policy standpoint and then leverage it with the money that we now have access to. And that's the marriage between policy and money. And
Mhm.
usually the world I live in is focusing on the policy, but we never have money. Now we got all this money and we got to match it with the policy. So it's a
Yeah.
problem. It's a great problem to have, but you got to do both of those and you got to do it because you're on a clock. As we talked
Mhm.
about from the beginning of this podcast, we don't have time to waste. So how do you do both of those and you do it quickly? It's going to be tricky because now we're talking about elected officials and we're talking about voting and we're talking about feelings getting hurt and it's going to be rough. We'll see how it goes.
Well, just like anything else in Mississippi, we're going to have public interests and there'll be some back end private interests that, butt heads and will ultimately figure out some path forward. And so what we want to do here is, talk about all of the positive things that we can do to improve these 6 pillars, and encourage everyone on both sides to come together and compromise so that we can keep the patient in mind, keep access in mind. And then I just go back to sustainability. The basically public and private interests are going to have to come into play here. Like the funds can't all go to just public institutions in the state, and it can't all go to private institutions in the state. There's going to have to be a yin and a yang, a working together. And I think that's probably the thing that we haven't talked about yet, but where I see, especially with $200 million, you're going to have both public and
Mhm,
private interests at
mhm,
play here.
mhm,
And some of those interests will conflict at times, and hopefully they're keeping the patient at the center of that interest. But it will be interesting to see how that plays out, with the powers that be that are going to determine the RFPs and the funding and everything, because there are tons of public institutions in the state that would be better suited for a lot of the programs that they have
mhm.
here.
That's
And
right.
there are others where it's like, hey, I think we would benefit from, a variety
Mhm.
of, applications, models, solutions that we can look at and, maybe give a little bit of attention to each of them. So,
Absolutely.
ultimately it's not one statewide initiative or one statewide program or one statewide entity or company or it's no one single anybody in the state is going to accomplish this. And so
Mhm.
the reality is, lots of the public and the private side need to come together to
Mhm.
create like a solid cohort that's like, all right, we're going to use this as an opportunity to make Mississippi better.
Mhm.
It's not just going to be like, oh, well, I want to keep my department open so that I can keep my job. So I'm going to get this grant funding. Like,
That's right.
we need to think about sustainability for the state as a long term. Like, let's put aside some individual interests for a little bit and just think about Mississippi as a whole,
That's
and
right.
there is, I think there is a big thing to be said about that mindset, which will determine like how a lot of this plays out, how the
Mhm.
money's spent, how we're measuring things, the improvements that we're actually seeing. I don't know. I just go back to not to rag on the telecommunication side of things, but we go back to telecom and all of the telehealth grants that the telecommunication companies have gotten in our state, and we haven't seen an improvement in telehealth.
Mhm. Yeah.
So I
Yeah.
just think about those things when we think about access.
That's right. Well, and you talked about the measurables, how are we going to measure success? I think that's going to be a pivotal role in this is how do we measure that success and what are the benchmarks that we have and how do we compare it to the past? So I think that's important. And coming back to what you mentioned as well, um, I want everyone to understand that. So this money, and this is certainly my recommendation. There's actually a House bill and a Senate bill in play right now in session that I think will pass, and it alludes to this as well. The money primarily needs to go to rural healthcare because that's in the name of the bill, right? And it needs to go to transformation of rural healthcare. So it does not need to go into doing the same thing we've always been doing. This is not for sustainability purposes.
We're
I've
not
heard
funding
some people.
operations.
No, say that again.
We're not funding operations.
No, we're not funding operations. It can deal with some construction, but it has to be construction that is different. So if you've got a very old style of doing something and we need to do something a different way or a better way, and this is a more of a modern trend that might could go to some of that. But yeah, I mean, it's about transformation. How are we going to do things differently? And that there's been a lot of confusion on that. I've seen some news articles and some people comment on the cuts to CMS and trying to say that the Rural Transformation Fund is not going to do anything compared to the cuts to CMS. Well, we're talking about apples and oranges. Yes, there were cuts to CMS. We're not talking about that today, but there were cuts to possibly Medicare, Medicaid. What those will look like, especially for states like Mississippi, I don't know. I expect minimal impact. This is not that. We're talking about different buckets of money. This is not intended to try to make up for cuts to CMS. This is intended to completely transform the way we deliver healthcare in rural areas of the state.
Mhm.
So if you want to complain about reimbursement being cut, that's fine. That's a whole different conversation. This is different than that. This is about transforming what we're doing and doing it, like you said, sustainably for the long term. So I just want people to understand that. And I do expect some of this money to go to urban entities, but
Mhm.
with the goal, because they have to reply to an RFP, they have a goal, they have benchmarks that they're going to have to meet. The goal is not to sustain urban care or to transform urban care. It is to transform rural care. And we do have urban entities that serve primarily rural areas. They will get some of this money, most likely. We could name them off right now if we chose to. Don't be surprised when you see large urban areas get some of this money, but understand if we do our job right as a state, that money will be used specifically for delivering and transforming care to rural areas that they cover and they serve. And we need that. But at the same time, my strong desire for this is for the money to be used for rural areas to rural entities, rural communities, rural hospitals,
Right.
rural clinics,
Absolutely.
rural providers, or businesses that are in those communities serving those patients. And so you're going to see a mix of both. I would very much want to see most of that money go directly into the rural areas, but understanding that we have very large urban players that serve rural constituents, and they too should get some of this money because it will inevitably benefit those rural communities themselves.
100% agree. I'm curious, to go back to the metrics run, when we think about metrics that are important or move the needle, what is one that, like, what is the number one metric that kind of comes to mind for you?
It's a good question. And that's a hard question because, so many of the things we talk about are they lead to improved metrics, but it takes time. And so how you dashboard yourself, I think the Department of Health has struggled with this because they want more of a quicker dashboard so we can see in real time if something is of benefit, but we haven't seen it. So, the things that I think of in a perfect world, if we could measure the obesity related illnesses, I mean, literally, and I hate BMI as a measure, but if we could do, blood pressure, A1C scores, things like that, that we could measure something that is very specific and data driven. And we do have data for it through both our EMRs for the different facilities and our insurance companies that have gathered that data. I would love to see a dashboard that included things like that.
Mm.
I would love to see one from a workforce standpoint to see how many beds are used and unused in hospitals, what their surge capacity is. I'd love to see ambulance coverage and average time to go to pick up a patient. How many times has a smaller county had to go without having a full capacity of vehicles? Things like that, I would love to see in a
Yeah.
dashboard form and something public for we all of us to be able to go on there and monitor and see. And just like you look at the stock market, you look at a day, you look at a week, you look at a month, a year, and you see it go up and down. I would love to see a true dashboard that we can all watch and monitor, because that's part of this issue we talk about here. Everything we talk about is so long term, you don't care on a daily basis about the long term. If we can all buy into the idea of we want Mississippi to get better and we ourselves are going to get healthier, and here's our metrics and here's our dashboard and here we are, it's all of a sudden like we're all on the same team and we can get behind it because we see the scoreboard. I think if we could do something like that, it would make such a bigger impact. But I know it is so hard to do.
It absolutely. And that's the one that I was thinking through. It's like, I mean, yeah, like you just hit it on the head. The metric you can't really measure is buy-in. It's
Exactly.
the engagement. And that's the hard thing, because really it's several, like, at least for us, like we don't have like an engagement metric. We have several metrics that we use to give us an engagement score. You know what I mean? And that to me is like the differentiator in the practices that we work with. Like the higher an engagement score, the more engaged that honestly everybody is. The patient, their caregivers, the practice, the physicians, the nurses, the more engaged that everyone is in the system, the better that it does. The more that people are bought in to this system. And that's the other tricky part is, yeah, you got some people that want to make a change and make a difference, but healthcare is no different than any other industry. What I mean by that is most people are going to show up every day for a job and they're going to clock in and out. And unless it's going to make a difference in their paycheck, they're going to continue to do what, like, if I'm getting paid to do this, why would I do extra when I don't get paid extra, or
Exactly.
some of those things. And so that goes back to incentives and incentives being aligned. Um, you know, but yeah, buy-in, like if only we could measure buy-in, because that's the thing that makes a difference.
That's right.
What does buy-in look like for a doctor, for a patient? Because, I think honestly, with some of the conditions that are thrown out, blood pressure control and A1Cs, those are major. Like,
Mhm.
yeah, like those are big things. The high rate of arthritis is a little concerning to me,
Mhm.
which, could be inactivity, poor
Yeah.
blood flow, other things like that contribute
Could
to
be.
it.
Yeah.
Just overall, education, kind of like we talked about earlier, like, hey, do you know what happens? Like, if you don't just try to exercise a few times a week, like, you hear people say like, oh, like, well, I'm just a 5 hour sleep a night kind of guy. I can function fine on 5 hours. And it's like, no, your body's breaking down. It's just figuring out how to adapt to
That's
the
right.
little bit that you're giving it. And
That's right.
a lot of these chronic issues that are causing issues, or these chronic issues that are causing all of these other downstream issues within the healthcare system, could just be prevented through, healthier lifestyles and whatnot.
That's right.
And that, hey, that's something I hadn't thought about from a business opportunity, or, um, healthy living, some business around healthy living or lifestyle. I don't know how it would get funded. I think I don't know. I'm sure somebody would pay for it, but
Hey, possibly part of the RFP. We'll see what comes
yeah,
out. Well, there may be something like that. I would encourage anyone listening to this to really think creatively, think outside the box. What are some things you could do with this money that might fit some of the guidelines that we've talked about today, and how could you use that? And we don't know, it may
Well,
not be a fit, but
I was thinking, Ryan, if we want to reference like our first podcast, wasn't it the Ambient AI podcast?
yes.
So think about this when we talk about, things that actually move the needle. If you had every provider in the state, every practice, every facility, and you incentivize them to implement an ambient AI technology, and this is not a pitch for Link. I don't have an ambient AI technology. But let's say that you implement an ambient AI technology into every clinic. Well, think about how much time a provider spends charting and documenting after a visit now. 20 minutes, 30 minutes. Well, we use an ambient AI for what we do. And one of the beauties of it is not only does it transcribe the phone call, but it also gives you a wonderful, beautiful soap note that
Hmm.
you probably wouldn't have been as detailed with on your own.
Hmm.
And then it'll give you recommendations or suggestions for follow-up care or what to talk about at their next visit and some of those things, those tools like that as a cost savings measure so that you can spend more time with patients because, you look at different studies and patients will change providers and a lot of I think some studies show that like 60% of Medicare patients are willing to change their provider if they're not responsive or they don't feel like they're getting the care that they deserve. And so just implementing ambient AI as a tool, which you're not necessarily going to get paid more for it, but what it does is enhances your care model because
Hmm.
now you can actually talk to the patient and you're not talking to the patient, just listening for certain responses because you need to write those down so that you can chart on them later. The ambient AI technology is going to take care of all that for you and you get to have a true conversation, truly build a relationship. It's not
That's
just
right.
making sure that you get the answers to your questions. Even that, giving a physician 15, 20 minutes back per patient per day. What does that do for his practice?
Life
Well, he's
changing.
probably got a better relationship with his patients. And now seeing 35 to 50 patients a day is not as cumbersome,
That's
you
right.
know?
That's right. The more time with patients, less time looking at a computer. They do what they were trained to do and what they fell in love with. They didn't fall in love with documentation. They fell in love with treating patients.
Yeah. Yeah. And that's, there's going to be lots of companies that, will apply for the funds or respond to the RFPs to offer services,
Mhm.
or maybe programs that want to do something internally. And I think, that is a good example for, the listener that is maybe just in a practice or a healthcare system that's like, well, if a bunch of people are doing these RFPs, well, like, what does that mean for me? Like,
Mhm.
so now there's opportunities for new services and whatnot. Does that, well, like what opportunities does that give me? Am I
Yeah.
am I going to have, a bunch of vendors beating down my door? Is it going to be an opportunity for me to, go find my own vendor and do an RFP and get paid? And so I
Mhm.
think there's that side of it that will need to be answered for like the end user of a lot of this funding, right? Because you're going to have people going out and getting funding to do something. And then there's vendors or practices or somebody downstream that's like, well, how does this benefit me? And what can I use it for or do
Mhm.
with it?
That's right. That's right. Well, on that note, Will, thank you for your time today. Enjoyed the conversation. For everyone listening,
Always.
be looking for those applications to come out, the RFP from the state of Mississippi or whatever state you're in. They should come out soon. They may already be out by the time you watch this podcast. We hope we gave you some good ideas, though, of what may be to come and some things that you might be able to apply for, whether you're a vendor or you're a provider or you're just a rural community and you're thinking, hey, we need all of these things. There may be a role for you in this. So if you're before the RFP process, I just encourage you go ahead and prepare yourself, prepare your community, build partnerships. Those are all good things here in the short term and in the long term. We wish you the best of luck. Please let us know if we can help you in this in some way. And together, hopefully, this will truly transform rural healthcare. Will promote telehealth, telemedicine, and all the various forms of technology in healthcare we've talked about, which, of course, is the reason why this podcast exists because we love talking about it. So, Will,
That's right.
thanks.
Yeah. Thanks, Ryan. Until next time.